Okay, so today we're going to talk about treatment of substance use disorders. Just to review, this is very important. The agonist spectrum, especially in substance use disorders, we're going to be using a lot of antagonists and a lot of partial agonists. All right. Some agonists also, but mostly partial agonists. All right. Pharmacokinetics, pharmacodynamics, whatever medications you're using to treat the substance use disorder, just understand what enzymes will break it down, because if someone takes another medication, it will have some interactions, all right? Also understand the pharmacodynamics of how the medication works, because sometimes you might give a certain medicine and it might counteract other meds that other specialties might prescribe, right? Like for instance, like beta blockers and someone who's using asthma medications, right? Upregulation, downregulation, very big part about substance use disorders also, because a lot of the dependence and the tolerance is due to upregulation, downregulation, right? So what we're trying to do technically is we're giving someone a medication to help manage their addictions, and it's going to try to reset their neurons, right? So if the neurons are upregulated, we're going to give them medications to give it a chance to go back to the way it was before, right? Or vice versa. Malfunctioning brain circuits and addiction, all right? So if someone has an impulsive behavior, what's the difference between an impulse and a compulsion? You guys know? What is the difference between an impulsive behavior and a compulsive behavior? What do you think?
Impulsive, you're not thinking about it, it's automatic.
Well, you're both not thinking about it, actually.
Hmm.
What do you, so what's it?
Impulsive is more like you can't control yourself from doing something in the moment, whereas compulsive is more of um, like a repetitive behavior that you do to prevent something negative.
Good. So usually something starts as impulsive, right? So say the first time, I want to have fun with someone and, I drink alcohol, right? I do it enough times. I walk by the liquor store and it almost becomes like automatic. I walk to the liquor store, it's automatic for me just to compulsively go inside and buy beer or liquor or whatever, right? So in the brain, something starts impulsive, and what we believe is that it starts in the ventral striatum, right? The ventral part of the striatum, which is the motor pathway, right? The more you do it, it starts to move, and it starts to start working in a different circuit, which moves it from the ventral striatum to the dorsal striatum. All right. Just understand the reason why, you don't have to memorize that, but just understand the concept that once it becomes compulsive, it's a little bit harder to treat, right? Because it's like a motor pathway disorder, right? It's almost like you're not thinking about it. People are like walking to the liquor store or walking to the drug dealer and getting the drugs or whatever substance they're using, and it's almost like they're not thinking about it, right? They just do it reflexively. Impulsive, you're not thinking about it also, but when it's impulsive, you can kind of treat it a little bit too. Once it's compulsive, it's a little bit harder to treat, right? The longer it happens, it becomes more repetitive. And of course, there's psychological dependence and there's physical dependence too, all right? We'll touch on that later on. Parts of the brain, once again. So one of the theories about why some kids are more prone to addictions, right, or impulsive behavior is because the dorsal lateral prefrontal cortex, or the frontal lobe of the brain, tends to develop at a later age, right? So for males, sometimes late 20s, for females, early 20s, right? And what's happening is there's development in the brain that's not happening in sequence. So the striatal pathway, or the reward pathway, which is the ventral tegmental area, right, to the nucleus accumbens, or the ventral striatum, is developing faster than the frontal lobe, right? So I'm sure you guys have heard of top-down inhibition. Top-down inhibition means that your cortex, or your frontal lobe, is kind of telling you, wait, don't do this, don't drive, don't drink while you're driving because you might get into an accident, right? So your frontal lobe is overriding it and you might not do it, right? But when someone who is younger and doesn't have a fully developed frontal lobe, they might not have that top-down inhibition. So they're more limbically driven. Limbically driven means that they're driven by their lower part of the brain, or the midbrain. So they just want to do, goal-seeking behavior or pleasure-seeking behavior. That's why kids do that sometimes, right? It's fun. I just want to do it. I want to do it. If it's fun, why not, right? Or YOLO. What does YOLO mean? You only live once, right? So again, this is the mesolimbic pathway, just breaking down a little bit differently. But this is how the mesolimbic pathway becomes kind of, sabotaged by the substance use disorder, right? So if you look at the ventral tegmental area, right? It's connecting to a GABAergic nucleus accumbens neuron. All right. So what's happening is, you notice there's a connection there from the opioid neuron right there. See, cannabinoids are there, also alcohol is there, and there's nicotinic. So if you look at this, just stare at it for a couple of seconds. I'm not going to say anything. Just look at it. Try to digest it for like 30 seconds. Then we're gonna break it down. All right, so the gist of this is, look, there's blue, which is the opioid receptors, right? Which is why you take an opioid and it stimulates pleasure, right? Because it's going to cause your dopamine and your VTA to increase, connection to nucleus accumbens, and it's going to cause pleasure, right? Nicotine also, there's a connection between nicotinic receptors to the VTA, right? That's the pleasure pathway. So anything that hits that pathway in your mesolimbic pathway is going to cause pleasure or goal-seeking behaviors, right? Pleasure-seeking behaviors, right? Cannabis also as well, right? Cannabis will connect to that. That will also cause your VTA to secrete dopamine. And whenever your VTA secretes dopamine and it hits the nucleus accumbens, guess what? That's a pathway that becomes rewarded, right? Any behaviors that start impulsively is going to be in the ventral striatum, right? The more you do it, the impulsive behavior gets embedded kind of like in your brain, and it starts moving to the dorsal striatum. Dorsal striatum is motor, right? So it becomes almost like your body's moving, but you're not really thinking about it, right? That's a very hard cycle to break once it gets to that point. All right, so opioid receptors connect to the VTA, nicotinic receptors from cigarette smoking. That's why it's very hard to stop smoking cigarettes. And of course, cannabis as well. People do use marijuana because it makes them feel good, gives that euphoric effect, especially the THC. And that's pretty much the extent of it. Any questions with that? I mean, you don't have to memorize this diagram. Just understand that there's a connection between all the different substances to the ventral tegmental area and its connection to nucleus accumbens, right? Which increases dopamine secretion. Therefore, when you have increased dopamine secretion, especially if it hits it really hard, a very high potency medication, right, that hits dopamine hard, let's say like cocaine, it's going to be reinforcing. That's why a lot of going back to our lecture last week or a couple weeks ago when we talked about the stimulants, right? The reason why I favor extended release amphetamines as opposed to immediate release amphetamines is because extended release doesn't hit that pathway hard enough for it to cause, a high risk of substance abuse, right? You give someone IR Adderall, and the potency is going to be a little bit more. It's going to hit that receptor harder. There's a higher chance of them developing euphoria, and they're going to want to reinforce that again, right? You do it a few times, it's impulsive. You do it enough times, it becomes compulsive, right? Then people start searching for, amphetamines from the street, and they start sniffing it or using other ways to kind of increase that hit from the substance. Does that make sense? Any questions about that? No? This is another way of looking at it. This is the alcohol. So if you look at the arcuate nucleus, opioid neuron, all right, opioids will also increase pleasure, right? So a lot of times we look at opioids as the pleasure part of it, right? But dopamine is more in for the seeking behaviors, right? So you're thinking about, okay, I can't wait to get this substance because it's going to feel so good. That's mediated more by dopamine, all right? When you get the substance and you actually take it and it feels good, that's mediated by opioids, all right? Once again, dopamine is pleasure-seeking behaviors, right? And opioids are actually the feeling of euphoria that you get. Does that make sense? Okay. So dopamine, drive, you can remember that way. Dopamine is the drive for the pleasure-seeking behavior. And opioids are actually what stops the euphoria from it. So sometimes we use medications that are opioid antagonists. What's a medication that's an opioid antagonist? Do you guys know? You did the reading?
Methadone.
No, methadone is not an opioid antagonist.
Naloxone.
Naloxone is one. You have the short acting, and what's the other one?
Naltrexone.
Very good. Naltrexone, which is longer acting, right? So naltrexone is not a rescue medication. Naloxone is a rescue medication, all right? So if you block the opioid receptors, sometimes you can help behaviors that are pleasure-seeking. For instance, kids who are self-harming, trichotillomania, that are plucking their eyebrows, right? You would think it's painful, but sometimes pain could be pleasure, right? So they're kind of being they're reinforcing that behavior because when they pluck or when they headbang or they do self-injurious behaviors, at first it's impulsive, right? Then it becomes compulsive. So a treatment, right, that's off-label, but with evidence is using an opioid antagonist, naltrexone, for self-harming behavior. So you'll see that sometimes. Binge eating disorders also sometimes we use naltrexone, right? Someone's eating a lot of food. You don't want to reinforce that pleasure-seeking behavior when they eat. So what do? You block opioid receptors, right? You give them naltrexone, and in theory, when they eat, they don't get that same reinforcement from eating, right? That euphoria is kind of blocked because the opioid receptors are blocked. Therefore, you can work with them through therapy to kind of, wean off that behavior, right? Does that make sense? So these pathways, I mean, I can go into detail about it, but clinically, I mean, if you just have a general understanding, you'll understand why we're using specific treatments. So you don't have to memorize this, but just know there's connections to the VTA and nucleus accumbens coming from the arcuate nucleus, which is opioid receptors, right? That's why opioids are so reinforcing, and alcohol as well through the GABA interneuron, right? I know people get confused with the GABA. I know a lot of you ask me, how do you know if someone has 5-HT2A or 5-HT1A on the GABA interneuron? And the answer is you don't know, all right? People have receptor profiles that are based on genetics and based on experiences, okay? The reason why I'm saying that, because epigenetics is very important. What is epigenetics? Do you guys know? What does that mean? Epigenetics. Epi stands for environment, and genetics stands for genetics, obviously, right? So how does your environment affect your genes? So people have a certain genotype, right? That's the genes that you're born with, right? That's what you have, but a phenotype is what's actually expressed. So the phenotype of your genes are going to be expressed through your behaviors or through your experiences. So for instance, a kid who experiences, we call them ACEs, adverse childhood experiences, right? They might have less, serotonin reuptake pumps, right? Or they might have a hyperactive amygdala, right? Or they may have a less of a connection with their underdeveloped frontal lobe to their amygdala. Therefore, they can't override those experiences and they might be at risk for PTSD, right? Or they might be hypervigilant. And you might need to give them an SSRI to increase the serotonin there because they don't have enough receptor pumps to begin with. You understand? So your body will develop, a certain amount of receptor profile based on your experiences. If that makes sense. So unfortunately, in psychiatry, we do have genetic testing, but it's not really validated just yet, right? There are some tests like, SLC6A4, which can actually see how much of the serotonin transport genes that you have. But depending on, ethnicity, sometimes it's validated, sometimes it's not. So we're not up to a point yet right now where we can do that testing with clarity to know if you have this genetic profile, I'm going to give you this medication that's going to work. All right. We're working towards it, but it's not ready yet. All right. Does that answer your question? So the answer is we don't really know. All right. And again, these connections vary based on your experiences. So people might have stronger connections. Some people might have weaker connections. It really depends on many things. These are some of the opioid receptors. If you guys don't know, we have mu, which is the U that looks like that. We have delta and we have kappa. All right. If you give someone a mu opioid antagonist, it's going to help with, pleasure-seeking behaviors, right? But at the same time, these are some of the effects of it. So these effects are actually activation. So for instance, you give someone an opioid, right, and it hits the mu receptor, they might have euphoria, right? But at the same time, they'll have sedation. And then, of course, like I said, physical dependence on it. You hit it enough, there's going to be tolerance. There's going to be changes in smooth muscle tone. So the exam, I'm going to put a lot of questions on how to see if a patient is having opioid intoxication or if a patient is having opioid rebound when they're not on it. All right. So know the symptoms of when someone's under withdrawal, and know the symptoms when someone is having intoxication. Right. The best advice I can give you is memorize one, whether it's intoxication or withdrawal, and therefore you can always switch it. Right. So if someone's having intoxication, when they have withdrawal, it's going to be the opposite. Like, so for instance, if someone's having opioid intoxication, they're going to have constipation, right? So obviously, if they're having withdrawal, it will be the opposite. They would have diarrhea. Does that make sense? If someone has opioid intoxication, they're going to have pinpoint pupils, right? So if someone is having withdrawal, they're going to have, mydriasis, right? Which is their pupils are going to be big. And the opposite. All right. If someone has pain, if someone's taking opioids and their pain response is dulled down, what happens when someone's having withdrawal? They're going to be very sensitive, right? They're going to be in a lot of pain, muscle pain. Right? So again, just pick one. If you want to memorize the intoxication, and then of course, just the opposite will be withdrawal. Any questions with that? No. This is what we use to measure opioid withdrawal, right? We use a COWS. So again, anyone work inpatient who's done this before with a patient? Anyone? Or is this new for everybody?
I used to work inpatient. I work outpatient now.
Good. And so I'm sure you're familiar with the COWS.
Yes.
You use COWS when you're giving someone opioid replacement therapy, right? So inpatient, we can give methadone, but outpatient you can't, right? Methadone can only be given in specific regulated places. So a lot of times we use partial agonists. What's the partial agonist that we use for opioid treatment? Starts with a B.
Suboxone.
Suboxone.
Buprenorphine.
No, buprenorphine. Yep. Suboxone is the brand name. So what is Suboxone? Tell me about Suboxone. It has
Suboxone.
buprenorphine in it, but what else does it have in there?
Naloxone.
Very good. Right? So is the naloxone working or no?
Not unless they override it, right?
Very
Try
good.
to override it.
Yeah, so naloxone only kicks in when someone tries to use the Suboxone inappropriately, right? When they try to melt it and try to inject it, or they try to use it, and it has to be taken sublingually, right? Any other way you're using it, the naloxone kicks in, so it kind of negates it, right? So the naloxone is a rescue drug. That's like similar to what medication are we talking about that doesn't work if you try to be? We talked about it in ADHD. It's a prodrug. Starts with a V. Vyvanse, right? Remember, Vyvanse is a safer medication. It's a long-acting version of amphetamine, right? Dexamphetamine to be exact, and it has lysine on it. So the lysine actually is on there and it activates it. The only way to take that lysine off is through your red blood cells in your stomach, right? So if you try to inject it, I don't know, you try to sniff it, I don't know, any other way, the lysine is on there, it's not going to work. You have to cleave the lysine off. So as long as the lysine is on there, the medication doesn't work. So the way you take the Vyvanse is orally. It goes to your gastric pathway and through your stomach, and that's when the lysine is cleaved off, and that's when the medication works, right? Any other way, it doesn't work. So it's kind of like a safety mechanism that stops people from abusing the medications, right? I'm sure eventually some smart chemist in college will figure out how to remove it. I'm sure kids are pretty smart and they'll figure it out, but as of right now, I don't think they've figured it out. All right. So check the resting pulse rate, right? Obviously, you're going to score it. Depending on how they score, mild, moderate to severe is when you would give them opioid replacement therapy, all right? What happens if you give someone Suboxone and they're not in active withdrawal? What will happen? Let's say someone scores a 5 when you give them Suboxone. And they use like a few hours before they went to the clinic. What's going to happen? You give them something called
Will the
precipitate.
Narcan kick in?
No, if someone is intoxicated and they're not having withdrawal just yet, so think about the opioid receptor, right? Imagine that graph I showed you before. Someone's opioid receptors, there's something strongly bound to there, right? The opioid is bound to the mu kappa delta receptor, right? You give them opioid partial agonist like Suboxone that has a higher affinity to that receptor, it's going to bounce off that opioid receptor, right? What's going to happen? They're going to have precipitated withdrawal, which means that their withdrawal symptoms are going to be much worse than if they had stopped taking the opioid, right? It's not going to kill them, but they're probably going to want to kill you in the office because they're going to feel like crap, right? Diarrhea is going to come, everything, all the withdrawals are going to come back very strongly. It's not good practice. So if you were working addiction medicine, you want to be as precise as possible. You want to make sure someone scores at least, I'm saying at least, some people even say higher, at least a 12, right? So you have to do this, cows, right? And you have to warn them, you have to be at least a moderate withdrawal. Patient goes, why? I want it now. Because if I give it to you now, you're going to get precipitated withdrawal and you're going to hate me. And you're going to feel like crap.
Can you explain that neurobiology of it again, of the receptor? The
Yes.
bounce.
Yeah, so a partial agonist usually has a higher affinity for a receptor, right? Like I think I told you guys last time, you can only have one neurotransmitter or one molecule bound to a receptor at the same time, right? Do you agree? You can only have one? All right. And since you can only have one, once that medication, I don't know, let's use, I don't know, heroin, right? It's bound to that receptor, opioid receptor. Once you give someone Suboxone, that heroin is going to be bounced off. So that partial agonist is going to stick on there. It's going to give them rebound withdrawal. And you're going to have really bad muscle pain. You're going to have muscle cramps. They're going to be sweating, diarrhea, right? Dysphoria. They're going to feel very bad, terrible, angry, irritable. They could be violent too and aggressive. So you don't want to give them precipitated withdrawal. So even if they're in moderate withdrawal, it's not going to be as bad as precipitated withdrawal. So that's why sometimes what happens is if a patient comes to the office and they're not in withdrawal, we actually have them wait around a little bit, like an hour or two in the waiting area. And of course, there's going to be a nurse monitoring them, checking them, doing a CALS maybe every hour, every half hour. Once they hit that moderate, right, score, then they'll knock on your door and say, hey, this patient is ready for Suboxone, right? Or buprenorphine, because they're in moderate withdrawal. And obviously, if you give them a partial agonist at that point, it's actually going to help with the symptoms, right? And you're going to give them, depending on what their symptoms are, you're going to give them a dose of Suboxone, wait about a half hour to an hour, see if they feel better. If they're still not feeling good, you can give them another dose, right? So therefore, the key is giving them opioid replacement therapy just enough to help them feel comfortable and not give them cravings that they don't use when they're outside the office. Does that make sense? It might take, sometimes it takes about 2 or 3 days to find the right dose. So sometimes you get lucky and you get it on the first day. But you're really trying to find the dose that helps them feel comfortable and they're not having withdrawals and not seeking that behavior again. All right? Which is partial agonist therapy. So usually what happens is we used to use long-acting opioid replacement therapy, right? You guys mentioned it before. Starts with an M. What is it?
Methadone.
Methadone, right? So people go to methadone clinics, but it could be stigmatizing. So we're kind of, they're still around, but we're trying to move away from it a little bit. So the algorithm used to be you would go with methadone, which is a long-acting opioid, right? Wean you off methadone, see if you can get off. If you can get off methadone, we'll switch you from methadone to a partial agonist like Suboxone and buprenorphine, right? And then if you're able to get off the buprenorphine, we will put you on long-acting what? Starts with an N, naltrexone, right? To stop the cravings. So if you can get someone off, but the key is, addiction is sometimes a chronic relapsing illness, right? So patients, it's not a matter of if, it's when they relapse. So sometimes there are some people that are very, they should be a no opioids, right? Get them off. But sometimes people can't get off it. They have such a hard time. So it's called harm reduction, where you will put them under very low dose, lowest effective dosing of opioid replacement therapy indefinitely, right? So they might be on Suboxone, 4 milligrams, right? So the ratio is about 25% of Suboxone to naloxone. So 4 milligrams, I think 4:1 is how it's done. 4 milligrams of buprenorphine to 1 milligram of naloxone. And the ratio kind of stays the same as you go up in dosing. All right.
I just have a question. I thought I was listening to the style lectures on like the NEI masterclass, and I thought he was saying you have to be using to get for the naltrexone to work, but maybe I misunderstood.
Using for naltrexone to work.
Yeah, I saw it was something he like. I could try to find the line, but I thought he said it a couple of times that you have to actually like be still using in order for the naltrexone to work, but I don't know now. I'll see if I can find it.
That doesn't make any sense. No.
Okay.
Maybe was he talking about opiates or talking about alcohol?
I want to say he was talking about opiates, yeah.
No, I think you're confusing with alcohol. We'll touch on that with the alcohol.
Okay. All right, thank you.
Yeah. You don't have to be using for the naltrexone to work. No. All right. Any questions with this? Understand the cows. You don't have to memorize it, but I do want you to know the scoring for mild, moderate, and severe. All right. Know the scoring. So know that once you go to 13 to 24, that's moderate. And know that they have to be around above a 12 for you to give them opioid replacement therapy. All right. Or if not, they're going to have precipitated withdrawal. That's important to know that. All right. I'm going to say it again. Opioid replacement therapy should not be given unless someone is in active withdrawal, right? And they should be scoring at least a 12. At least a 12. Because if not, you're going to give them something called precipitated withdrawal, which is going to be bad. These are medications that we use for opioid overdose, withdrawal, and addiction. All right. Like I mentioned before, we have methadone, which is long-acting. It comes in liquid. It comes in tablet. Naltrexone, which is Vivitrol is another name for it. It's a monthly injection. Buprenorphine is a partial agonist. All right. They do have long-acting buprenorphine now, which is called Sublocade. I've never used it, but I'm familiar with it. Usually people who specialize in substance abuse use that. Buprenorphine naloxone, which is the film. Common name for it is Suboxone. That's the one I'm comfortable using. What is lofexidine? It's a fairly new medication, but what is it? Idine is the key word. What med do you think is other med? There's other med you've talked about that have idine as the end of it.
An alpha-2 agonist?
Very good. It's alpha-2 agonist, right? It's a cleaner alpha-2 agonist that doesn't cause rebounds, hypotension, and it won't drop your blood pressure or your pulse, right? So lofexidine was first approved in Europe, and they were using it a lot in Europe, and past couple of years ago it was approved here in the US, so we use it here a lot now. And obviously naloxone is the rescue drug. All right, so these are meds that we use. So we have agonist therapy, right, which is the opiate replacement therapy, whether it's a partial agonist or a full agonist like methadone. And we have antagonists. Once, if you want to get them off and try to block the receptor, so it helps keep them abstinent, and that would be naloxone, short acting, and you have naltrexone, long acting. All right. Adrenergic receptor agonist, that's for the, so why are we giving someone an alpha-2 agonist? How is that going to help with addiction? What does it do?
It's going to increase dopamine.
No, doesn't increase dopamine. It actually works on alpha-2, which is norepinephrine. What does norepinephrine have to do with the whole pathway?
Does it help with like the withdrawal symptoms related to norepinephrine, like tachycardia? I think in your lecture you said goosebumps or something like that.
So when you give someone, I hate to use this term, but I'll make it simple, like a depressant, quote unquote, right? Very broad, layman's term, a depressant. What happens to your brain when you talk about tolerance and the fact that it's hitting homeostasis? You give someone a depressant, your brain is not going to have enough neurotransmitters, right? So in essence, it's going to increase norepinephrine, right? So you give someone a depressant, your brain is like, what's going on? I'm not getting enough stimulation. Let me increase norepinephrine from the locus coeruleus, right? To kind of stimulate you. What happens after that depressant is taken off? You have very, very upregulated receptors now, right? Very sensitive receptors. And that's why you sometimes get hypertensive. That's why sometimes what happens when you stop using alcohol and you stop using benzos? People can have seizures, right? It's a hyperactive state because your brain was compensating for a depressant, increasing all that norepinephrine. And now you stop the depressant and you still have all that extra norepinephrine with upregulated receptors and very sensitive receptors, right? So an alpha-2 agonist is an autoreceptor on the presynaptic neuron, right? What happens when you agonize in a presynaptic autoreceptor? It's going to tell that presynaptic receptor neuron to stop secreting norepinephrine, right? It's a negative feedback loop. So you give someone an alpha-2 agonist, it tells you locus coeruleus, wait, there's enough norepinephrine here, shut it down, and therefore it's gonna reduce the anxiety, reduce the tachycardia, right? It's gonna bring it down. Does that make sense? So again, it's a response to a depressant, right? Whether it a benzo, whether it be alcohol, or whether it be an opioid, right? Your brain is not getting the same stimulation. It's gonna compensate by your locus coeruleus. It's gonna start secreting a whole bunch of norepinephrine to try to get that stimulation back again, right? Once you stop the opioid, you have all this norepinephrine now, which is what? Going to stimulate your fight or flight response, right? Tachycardia, elevated blood pressure, hyperarousal, anxiety. Therefore, you give them an alpha-2 agonist. It's going to hit that alpha-2 autoreceptor. The locus coeruleus is going to say, okay, shut down the norepinephrine, and people will have relief of symptoms. Does that make sense? All right. Naltrexone versus naloxone, what's the difference? All right, very easy. Naltrexone is long-term, comes in injection. Naloxone is short-term. Okay, rescue drug. What happens if you give someone naloxone who is taking fentanyl? What's going to happen? Why is that dangerous? If someone overdosed on fentanyl and give them naloxone, you leave them alone, what's going to happen? You think you're going to see them the next day? No, they're going to be dead. Why? Because fentanyl has a very long half-life, right? Very long half-life. Naloxone has a very short half-life. So I've seen this happen numerous times in the ER when I was working CPAP, right? The nurses gave someone naloxone, didn't know that it was fentanyl, right? Because fentanyl is in everything now. It's odorless and it has no taste to it. People are putting fentanyl in everything, right? You give them the naloxone's working, short half-life. Then once it leaves the system, the fentanyl is still there, right? Because it's a very long half-life. The fentanyl goes back on the receptor and the person goes back to respiratory depression, right? That's why sometimes it's, especially if someone overdosed on fentanyl, you have to observe them, right? For at least 24 hours. Because, you don't want to leave them alone and all of a sudden the fentanyl's still in the system and someone goes into respiratory depression again, all right? How does an opioid cause respiratory depression? Why does it cause respiratory depression? What does it do? Where's your breathing pathway? What part of your brain? Your brainstem, right? So your brainstem has very specialized neurons, which actually tell you when to breathe when you're what? What has to build up in your body? Your breathing reflex, what builds up?
Carbon dioxide.
CO2, right? So you have CO2 receptors in which once CO2 starts to build up, your body's gonna have to breathe, have to do gas exchange, right? Breathe it out. When you give someone opioids, those receptors start not to work. So what happens is CO2 keeps building up. People start having less and less respiratory response, right? Their breaths go from 18 to 10 to 5 to all of a sudden it stops, right? So that's why people have respiratory depression, okay? So you would give someone naloxone, right? Call 911, they bring them to the hospital and they have to stabilize them there, right? The problem is fentanyl has a very, very high long half-life and a very high affinity too sometimes. So that's why it's dangerous. Any meds that have high affinity and very long half-life is very dangerous because it'll bounce off everything else and it stays on for a long time. So naltrexone, if you remember treks, long journey, like a trek, ox, if you guys know the Oregon Trail, I got that from someone, it's a little bit faster. So naloxone, rescue drug, naltrexone, long-term treatment, all right? Naltrexone comes in injectable. Naltrexone also comes in pills, but, you know, for the most part, it's more for maintenance treatment, all right? Signs and symptoms of opioid intoxication. I'm really focusing on opioids because number one, we have an opioid epidemic and you're going to see a lot more of that, all right? And we're going to touch on alcohol also, okay? Intoxication, they get euphoria, right? There's a rush. Then they get sedation with high doses, all right? Anesthesia, obviously, you guys know that. Autonomic hyperactivity, because we were talking about your body compensating for having a depressant, right? So your heart rate will go up, blood pressure will go up, your breathing will go up as well, okay? So like I said, this is intoxicating withdrawal. So you can pick intoxication to memorize that, and then just assume that the opposite will be withdrawal, all right? Or vice versa. Yawning, for whatever reason, I don't really know the pathophysiology of why people yawn when they're off of opioids, but it's a side effect of withdrawal, all right? Going to alcohol now. So if you look here, so for patients who are alcoholic, if you look in the middle here, the ventricles are enlarged. So the ventricles are enlarged, what does that mean? Is that less brain matter or more brain matter?
Less brain matter.
Less brain matter, right? So this pretty much you lose brain cells if you're chronically using alcohol. Okay, Wernicke's encephalopathy. Anyone know what this is? Wernicke's encephalopathy. Is it reversible or irreversible?
Isn't it like wet brain, essentially? Where's the terminology?
Is it called wet brain? I don't know. I've never heard that term before. Why? Why is it called wet brain? I don't know.
It's almost like a dementia in a way, where it can
It
lead
could
to
look like
that.
it. Yeah, it could look like it. Right. So it's very important that you give someone thiamine, right, before you give them glucose. Why? Because it's going to cause something called Korsakoff psychosis, which is irreversible, right? So thiamine is part of your pathway when it comes to like metabolism and your body's ability to produce energy, right? I don't want to go too much detail about it. But the problem is if you give someone glucose, right? Say if someone gives them an IV bag with glucose in it and they had Wernicke's, your body's going to try to produce energy with that glucose and there's no thiamine there, it's going to cause destruction of the cells in your body, right? It's very important. So make sure you give them thiamine. So that's why a lot of times an inpatient, if someone's an alcoholic, right? Sometimes they give them injections in the beginning and then they give them PO doses of thiamine, right? That's important, all right? So these are some of the symptoms of Wernicke's encephalopathy, all right? So you have changes in mental status, memory impairment, so they might be confused. You ask them, you know, where are you? Who are you? Do you know where you are? You know what the date is, right? They might be confused about that. Sometimes you do the lateral gaze test, you move your finger across and you try to get them to do the H, right? And they'll have something called ophthalmoplegia. What's ophthalmoplegia? So normally when you follow the H, right, your eyes are moving concurrently together, right, bilaterally. They're both going to move smoothly, right? If someone has ophthalmoplegia, one eye might not actually move, or one eye might be moving slower than the other, so it might drift a little bit. So it's not going to be smooth tracking with the eye, right? Cerebellar dysfunction, they might off balance, they might be at risk for falls, right? Usually it's feet. And, you know, nutritional deficiency, they're not eating, they're just drinking alcohol, right? So a lot of alcoholics are not getting sufficient vitamins, right? So that puts them at higher risk of Wernicke's encephalopathy, all right? So usually there's a triad, right? Is the patient confused? I do the test with the H, with the eye movement, and one eye is not moving as smoothly as the other eye, right? Or there might be nystagmus, but the eyes are kind of dancing, shaking a little bit, right? Patient is walking towards the door and they're off balance, right? So that's three of the three symptoms, right? That's a triad. That's called Wernicke's triad, right? They're imbalanced. They have issues with eye tracking and they're confused. They're not ANO times 4. Any questions for that? All right, so Wernicke's is not just from alcoholism, but we do see that a lot. It also can happen from cancers. It can happen from pregnancy if someone's vomiting a lot. Bariatric surgery. I have a few patients that we have to make sure we monitor the B vitamins because they had bariatric surgery. Eating disorders, you'll see that too. If patients are purging a lot or restricting and they're not eating, they could also have risk for Wernicke's encephalopathy. So even though we're talking about this in the context of alcohol right now, it can also happen in other different states. All right. So treatment is, you know, you have to give them thiamine. All right. If you give them glucose without thiamine, it can progress and make it a lot worse. Okay. This is CWA, which is alcohol withdrawal. All right. So anyone familiar with this? If you're a get patient, you should know what this is. So it depends on the prescriber. Some people like to use Ativan. Some people like to use Librium. I mean, I've used both, so it doesn't really matter. But what you're doing is you're giving someone. So what does it mean when a medication is cross-tolerant? You might see that in the book, cross-tolerance. What does that mean? Cross-tolerance means that the substance that you're giving them is the same to the substance that the thing. Cross-tolerance is like benzos and alcohol, right? So again, someone's drinking a lot of alcohol, right? It works on GABA. What does GABA do? It starts to depress your neurons, right? What is your body going to do in response? It's going to start producing more neurotransmitters, right? Or norepinephrine to try to stimulate you. And then what happens when you take off the depressant or the alcohol? You have a hyper state, right? You have too much neurotransmitters. So that can lead to seizures. That can lead to psychosis sometimes, right? So what happens, you give them benzos because it's cross-tolerant with alcohol, and you taper them, right? You usually do a benzodiazepine taper. You find the dose that keeps their CWA under control, and then over time, over a couple of days, you start reducing it, right? Same as if someone was addicted to benzos. You do the same thing, right? Someone's addicted to Xanax. You put them on, you know, a longer acting benzo and you taper them off. Maybe Klonopin, maybe Ativan, right? And you wean them off. Does that make sense? Right? So you're giving them a substance that's going to take the place of the substance they're using, but it's going to be in a controlled setting and you're able to taper them off, right? So you're doing the CWA to make sure their CWA is 0. If the CWA is 0, that means that your substance you're giving them, which is the benzo you're giving them, is meeting the needs of their body to not give them withdrawal, right? Over time, you start tapering it off and the body starts to adapt. Once the body continues to adapt, you lower it again and you keep lowering it until eventually the key is getting them off, all right? But the difference is with alcohol, you can also put them on naltrexone. Okay, so to answer your question about someone's drinking while they're using naltrexone, that's part of the psychological treatment of alcohol, right? It's called drinking to sobriety. Anyone heard that term before, drinking to sobriety? Right? Because if you're giving someone naltrexone and they're not drinking, in their mind, they're still going to be like, well, if I drink, I'm going to feel good, right? So in a way, you kind of have them drink.
Mess me up.
Sorry, if you're not, please mute yourself. Galaxy S9, what was that? Sorry about that. I don't know who Galaxy S9 is, but
So you need the alcohol like a little bit. Is it because of the mu because the alcohol is hitting the mu then? Like receptor? Like how come you wouldn't need to have like the, you know what I'm saying? Like the opioids? Like why wouldn't you be needing to use with the opioids, but you need a little alcohol for
no,
it to
because
work?
it's a psychological part of it. So
Oh, okay.
people have a physical dependence to something, right? Physical, but the psychological part is still there. They still feel like if they drink, they're going to feel that euphoria, right? So think about it like when they do the behavior, they don't get reinforced and they don't feel that pleasure. And therefore they go, why am I going to do it? It doesn't feel good anyway. So it kind of helps that psychological pathway of it. Does that make sense?
Yeah, that makes sense. Yeah, thank you.
So that's why the term is called drinking to sobriety. Because you can drink, but it's not going to reinforce it. So you're like, why am I going to drink? Right? So that's probably what Stahl meant. You can drink alcohol with an naltrexone on board, and it's not going to be reinforcing because the opioid receptors are not going to be hit in the arcuate nucleus, right? So there's no pleasure. Why am I doing it? Why am I binge eating? No pleasure. That's the rationale.
Got it. Okay, let me go follow.
Galaxy S9, I'm going to mute you again, or I'm going to kick you out of the room. Last warning. All right. All right. Any questions with that? With the CWA? Does that make sense? Cross tolerance with benzos and alcohol. you're gonna put them on a substance to wean them off. Same concept, but actually opioids too, right? You're using Suboxone. You're gonna try to wean them off the Suboxone if you can, lower the dose, and see if they're able to get off it, right? Once they're off it, you put them on naltrexone as maintenance therapy, right? To hopefully block those opioid receptors, therefore they're not gonna get the euphoric effect. When would you not give naltrexone? Another contraindication with naltrexone. If someone's on chronic pain management, right? Let's say someone has some kind of illness in which they need to be in chronic opioids for the pain management. You don't want to give them naltrexone because then their pain is not going to be in control. Or the pain management doctor is going to have to find another way to manage their pain. All right. Or if someone's going to the dentist to get oral surgery, right? Their wisdom teeth removed. You probably should warn them, let me know because I'm going to have to stop your naltrexone injection. Right? Because then they go to a dentist and the pain meds are not working at all. Right? That's important.
Can you go back to people that are withdrawing from alcohol, they have seizures? Is it because you said because of the upregulation of all the receptors now, since you're taken off, because I guess because alcohol hits so many? Is that what it is? Or
Yes. So just to be upfront about it, I'm not an addiction specialist, but I do have a general understanding of it. There are some addictionologists or addiction psychiatrists that don't use benzos. It's a fairly new thing too. So I just want to put it out there just in case you read about it. There are some people that don't want to use, because think about it. I mentioned cross tolerance, right? They're like, well, if someone's an alcoholic, I'm going to put them on benzos. What happens if they get addicted to the benzos, right? It's like one dangerous substance to another dangerous substance. So there is a branch of some addictionologists, but this is their specialty. They do this all day. And there's actually some success rates in which they only use anticonvulsants. So you see Depakote, because like you mentioned, right? Seizures are dangerous, right? Someone has a seizure, they hit their head and they can have a brain bleed, right? But if you put someone on Depakote, or you put someone on topiramate, or you put someone on another anticonvulsant, right? The danger of the seizure is gone. They're going to have the hyperactivity, and you can give them alpha-2 agonists, right? You can treat the symptoms. So you could do it that way. And topiramate's another, they use Topamax also. But that's another way of treating it too. Sometimes people use a little bit of both. Sometimes I put someone on anticonvulsants at the same time they're giving them benzos too to help. I mean, there's different ways to treat patients, I guess, depending on maybe if someone has bipolar disorder and they're already on Depakote, right? For bipolar mania, they might stay in the Depakote and their risk of seizure might be less. Maybe they might raise the Depakote. It depends. See, there's many different parameters there to adjust it, but just to understand. Did I answer your question? So the seizure is due to the hyperactivity of your brain compensating for the fact that you're giving someone a depressant or someone's taking a depressant.
okay, yes, thank you.
Any other questions? No. I think it's called the Kawasaki method. It's a method of detoxing people off of alcohol, and which they use anticonvulsants. All right. But this is not something I would probably feel comfortable doing outpatient. Maybe if, do it inpatient with a full team in front of you. Most people still use the old and, the true and tested method of using benzos, right? But there might be a contraindication to it. So if there is, then you would use the other method, all right? This is just the different medications we use to treat alcohol. So obviously you have oral naltrexone, right? Usually 50 milligrams. Now, the thing about naltrexone is that you have to make sure you check liver functioning, right? If someone has an elevated ALT, AST, right, make sure you check it a few times. I would probably make sure that they don't have any inflammation in their stomach, all right? Because it will cause that to get even worse. So make sure you do baseline. I would do Chem 20. It'll give you liver and kidney functioning on there, all right? Oral naltrexone blocks opioid receptors, like I mentioned. You block the opioid receptor, you block the pleasure-seeking behaviors, right? You stop the pleasure, so people don't have that reward, okay? Again, the precautions there is you must be free 7 to 10 days, all right? Why? Precipitated withdrawal, all right? Naltrexone is the same as oral naltrexone. It's an injectable, given once a month, okay? What is a camprosate? It helps with cravings also, all right? And make sure you check kidney functioning with a camprosate because it's metabolized in the kidney and excreted in the kidney. So if any has impaired kidney functioning, you can give them a camprosate, all right? So make sure you check creatine clearance and also check GFR. Okay. Disulfiram. So what is disulfiram? People still use it, but sometimes it could be dangerous if patients have a lot of like medical comorbidities, because if someone takes it, they can become very sick, right? What does disulfiram do? It stops the breakdown of what?
Alcohol?
Okay. To what? So there's a alcohol gets broken down to something called aldehyde dehydrogenase, which if it builds up to a certain amount of time, it actually makes you sick, right? The problem with disulfiram, right, which I know this because I work in schizophrenia, is that if a patient has a history of psychosis and given disulfiram, there's actually a higher risk of them developing psychosis. So unless someone specializes in psychosis or schizophrenia, they might not notice this, but since you guys are being taught by me, I want you to know this just in case you go into patients with psychosis. Disulfiram also breaks down or stops the breakdown of dopamine to norepinephrine. Obviously, you guys know norepinephrine is created from dopamine, right? So if dopamine is not being turned to norepinephrine because disulfiram is stopping it, your brain is going to have a buildup of dopamine. So if your brain has a buildup of dopamine, they can have higher risk of psychosis. All right, so be careful of that. If someone has a family history of mania, because remember, too much dopamine can also cause mania, or a family history of psychosis, I probably will not use disulfiram with them. All right, it's called disulfiram-induced psychosis. Okay, because it stops the breakdown of dopamine to norepinephrine, right, by inhibiting an enzyme called dopamine beta hydroxylase, DBH. Dopamine beta hydroxylase breaks down dopamine to norepinephrine. When you stop that breakdown, right, dopamine starts to build up in the synaptic cleft, right? Too much dopamine will predispose someone to psychosis, especially if they already have a family history of psychosis, all right? Make sense? Acamprosate is given to help people with alcohol cravings, right? Make sure you check kidney functioning, all right? Because it's metabolized and treated to the kidneys. Naltrexone, make sure the patient is having moderate withdrawal, all right? And make sure you check liver functioning. Any questions? This is fairly, common in kids. So if you're working in child psychiatry, and I work child psychiatry also, kids will use, inhalants. So make sure you ask parents, are you finding empty bottles of paint or toluene, which is like a gas that people sniff, all right? It can be in finger polish, spot removers, paint. Kids will sniff it and they'll get high, all right? So make sure you screen for that. This is a PET scan of patients with, who have methamphetamine use disorder. So notice how a healthy person, right? If you look at it, look at the brain there and look at what happens after 14 months of abstinence. It kind of goes back to the way it was. So what I usually tell patients is, even if you've been abstinent for a month, you're not going to see the full benefit just yet, right? I still feel the same. I still feel dysphoric. It takes up to over a year for your brain to reset itself, right? So that's the way I usually show this slide to patients who are trying to stay clean. And they say, well, I don't feel the same. Well, look, if you look at the slide here, it could take up to a year for you to start feeling. So it kind of motivates them that, that there's hope if they can stay clear of it, right? There is some studies out there that are using partial agonists like aripiprazole or Vraylar to help with methamphetamine use disorder. Why? Why do you think a partial agonist will help with that?
So they'll provide more like a net dopamine, like a positive.
It will. Very good, right? Similar to giving someone a little bit of opioid, like a partial agonist, like Suboxone, to stop the cravings, and it's harm reduction. It's better than them getting a full opioid agonist. You're giving them a partial agonist for dopamine, because remember, amphetamine, remember from ADHD, right? It works on VMAT, so it'll spit out dopamine, right? And it also stops dopamine from being reuptaken into the cell. So it's going to increase the dopamine release from the VTA. The VTA is going to hit the ventral striatum or nucleus accumbens very strongly. It's going to reinforce that behavior. But if it gives someone a partial agonist, right, the affinity for that partial agonist, in theory, will be higher than the dopamine that your body's secreting, right? So even though they're using methamphetamine, that partial agonist is going to stay at the postsynaptic receptor, and it'll stop them from becoming psychotic, getting the euphoric effect, and hopefully stop the cravings. All right. But again, the studies are still ongoing, but that's the science behind it. All right. Using a partial agonist with a higher affinity than the substance itself to stop the cravings and to protect the person from that. All right. Make sense? Cannabis. All right. So just know that, cannabis now, obviously, cannabis is legal, but cannabis affects the whole body. We're still kind of trying to understand it. The body does have cannabinoid receptors. A lot of the cannabinoid receptors, right, CB1, CB2, are actually partial agonists. So your body will release, you know, anandamide, right? Which is like your body's form of cannabis, but most of the time it's a partial agonist. When someone takes cannabis outside, it's a full agonist, and your body's not used to that full agonism. So it can cause anxiety, it can cause psychosis. All right. Just know that marijuana, THC, and CBD together inhibits 3A4, right? So 3A4 could be your antipsychotics, it could be your benzodiazepines, it could be your statins, it could be a lot of medical meds too, right? 2C9 is Depakote, all right? 2C19 is Lexapro, Celexa, sertraline. So if someone smokes cannabis and it's inhibiting those medications, what's going to happen to those medications? Are the levels going to go up or go down? It inhibits it. It's going to go up. Very good, right? You're inhibiting those CYP enzymes, the levels of the meds are going to go up. Now, it might be a wash, right? For instance, I'm giving someone 3A4 medication, which is an antipsychotic, right? You're going to say, well, you're saying I smoke weed and it's going to make my medication levels go up, right? Why is that a bad thing? Will my antipsychotic work better then? What do you think the answer to that is?
You worry about worse side effects?
Yeah, you could have EPS, correct? Yeah. But so that's a pharmacokinetic interaction, right? If I'm telling you marijuana inhibits 3A4, 2C9, 2C19, that's a pharmacokinetic interaction, right? But what about the pharmacodynamic interaction? It being a full agonist and your body being used to a partial agonist. So that's what I tell patients. Sure. So for instance, someone's on Vraylar, right? It's a 3A4 medication, right? They smoke marijuana. The level of Vraylar goes up, and you would think it would be an increase in antipsychotic effect, right? But they might have increased akathisia. They'll feel restless. They're pacing around, right? But the marijuana itself at the CB1 receptor is a full agonist, which could be psychomimetic, right? So the patient will have increased psychosis and paranoia from the marijuana pharmacodynamic effect. And even though the effect of the Vraylar is going up, it's not going to match the pharmacodynamic effect of the marijuana, right? So you explain that to the patient. So it's kind of like, it's not even. It's not a 1-to-1 ratio. So the marijuana is a full agonist of the CB1 receptor. That can cause psychosis. The marijuana inhibits your 3A4 from the Vraylar, but it's not going to go 1-and-1 will be the same, and it's a wash. One might override the other. So people will still have psychosis, but they'll have the worst of both worlds. They'll have psychosis from the pharmacodynamic, right? And they'll have akathisia from the pharmacokinetic of the marijuana. So they're going to feel worse. So usually I say stop the marijuana, all right? Easier said than done, but. So we don't have any medications right now that we can give similar to opioids or alcohol to help minimize the cravings, right, of marijuana. They're trying to study it. There are some synthetic marijuana medications, but that hasn't really been proven yet that it's effective. So a lot of it is motivational interviewing, right? Getting them to a therapist that's trained in substance abuse to help them see why, it could benefit them to stop the use, right? So I have a patient who can't afford the rent, right? Okay, you're trying to say you want to save enough money to pay rent, but you're buying, $200 worth of marijuana every week. How does that match up there, right? If someone sees no problem with their use, they are in the what phase of Prochaska's theory. You guys will learn that next semester. But remember, there's different phases of people wanting to stop their use, right? There's the what phase? The pre-contemplation phase, right? Where I don't know why you want me to stop using marijuana. There's nothing wrong with it. It's fine. It's legal, right? Pre-contemplation. They don't see anything wrong with it. At that point, you can talk to them about all the special, effects of drugs, all the research about stopping it, and they can care less because they're in the pre-contemplation phase, right? Then you go to the contemplation phase. Oh no, maybe you're right. Maybe I would be able to pay my rent if I had stopped buying this marijuana. Okay, then you can start using the plan, right? Contemplation phase. Action phase. All right, now I want to stop. How can I stop marijuana use? I'm going to engage in therapy. Action phase, right? Maintenance phase. How can I stay off of marijuana use, right? Or opioid use or whatever, right? Pre-contemplation, contemplation, action phase, maintenance phase.
Can you go over the
question real quick.
pharmacodynamic part again about smoking, marijuana and antipsychotics essentially?
It's still fairly new and people are still researching it. So from my understanding that the CB receptor is one of the receptors that they think that causes a lot of the psychosis. And our body does stimulate that receptor as a partial agonist, right? With anandamide, which is one of our forms of marijuana or cannabis in the body. When you take it externally or, artificially, quote unquote, it's hitting it as a full agonist, and your body's not used to that. So it can cause psychosis, it can cause anxiety, it can cause paranoia, right? The symptoms people feel from marijuana use, intoxication, or apathy. They don't really want to do much. Just kind of like stay home all day, right?
So naturally, we are partial naturally, but when we're giving a
Naturally, your
full,
body,
then it,
yeah, your body isn't hit by a full agonist. It's partial, yes. All right. So it's funny because CBD, which is part of marijuana, right? There's THC, which is a psychoactive part. It's really the potency of THC that's dangerous, because if the THC is very strong, then of course they're going to have more of the, the psycho effect of it, right? The psychosis, the paranoia, all that. CBD kind of protects against that. So if the CBD ratio tends to be higher than the THC, it tends to be a little bit safer, right? Because CBD kind of helps against that. There's actually some studies now where they're trying to research CBD for psychosis, right? But again, it's very early on in treatment, and I don't know what the data is specifically showing at this point, but there's research for that. All right, that was the gist of the lecture. So let's talk about what's not clear. Any questions? I have a half hour.
should we know like hallucinogenics and what they do to the body as well, or just
Like
kind of
what? Psychedelics?
yeah, like I know that we use ketamine in treatment or esketamine, or regular, but like should we know more about like psilocybin or anything about like abuse with it or use, I guess, therapeutic use,
So psychedelics work on what receptor?
serotonin,
Which serotonin receptor?
5-HT 2A maybe?
Very good.
2A.
Yeah, they're very strong 5-HT2A agonists, right? So if someone's taking a psychedelic medication, they're very strong 5-HT2A agonist, right? That can also cause psychosis because it works through the GABA interneuron, the glutamate, right, on the top of your brain. So that downstream will increase dopamine, cause psychosis. So those patients, sometimes you give them very strong 5-HT2A antagonists like olanzapine, or atypicals, Latuda, or a good 5-HT2A antagonist. It'll help with the psychosis. So know that too much serotonin. Remember we talked about the schizophrenia, right? Too much serotonin and too much dopamine, in a very general sense, can cause psychosis. All right, so psychedelics can cause psychosis because of that, the 5-HT2A stimulation. So that's a contraindication. I did ketamine treatment for a year, not as a patient, as a provider. I worked in a ketamine clinic, so I was giving people ketamine. One of the contraindications was actually psychosis, a family history of it, right? Because I don't want to stimulate your 5-HT2A receptors if you have a family history of psychosis, right? Because it'll worsen it and make you manic or make you psychotic.
What about sleep? Will sleep be on this exam?
Yeah, we're gonna talk about that next week.
Okay.
So sleep and addictions are going to be the main part of the exam. Pain management, not really, because you're not going to be treating that as an NP. If you have questions about it, we can talk about it, but it's not going to be an exam.
I know Stahl went a lot into like cannabis and like the like benefits and associated risks and like on the 3 different levels. Do we need to know all those? Or should we just focus on like what you have in your slide?
Yeah, focus on what I have in my slides.
Okay,
But you
thank
should
you.
read the style too for your information, because it's good stuff.
Mhm.
Anyone going to APA in May? May 4th or no? American Psychiatric Association at the Javits Center. It's a pretty big event. If you guys are going, I'll be there, but what's a dangerous combination? Someone's using what and what? Someone's using opioids and something else. What other substance is one of the most dangerous combinations? An opioid and what? Another depressant.
Alcohol?
Alcohol, yes. And what's another form of alcohol?
Mm.
GABA, benzos, right? So if people combine, opioids and Xanax, what's the risk?
Respiratory depression?
So depression, right? Another dangerous combination is actually alcohol and stimulants. Why? This is actually a good. This is a good example because it teaches you how conceptualize addiction. Why is it dangerous for someone who is drinking alcohol and using methamphetamine? You think it would cancel out? You're taking a stimulant and a depressant, right? So it should cancel out, but it doesn't. Why is it a dangerous combination? What happens to your frontal lobe when you take alcohol?
Suppresses it?
Yes. So you have an inhibited frontal lobe, so the top-down regulation I talked about is not working, right? And your drive, your mesolimbic area is much stronger because you're taking amphetamines. So people will engage in very risky behaviors, right? Drive fast, sexual promiscuous behavior, gambling, right? Because your pleasure-seeking area from the amphetamine is upregulated, right? From too much stimulation from the amphetamine. And your frontal lobe is not there to tell you, hey, be careful, maybe you should slow down or not do this because you're gonna get an STD or you're gonna kill yourself, right? So that's a dangerous combination also. If someone's a chronic alcoholic and they have impaired liver functioning, would you still give them naltrexone? What do you think the answer is? The answer is actually yes. The answer is yes. Why is the answer yes?
Because the risk of the alcoholism would be higher than the risk of the liver problem. So you just have to monitor the liver closely.
That's true. Yeah, it's harm reduction, right? So sometimes there's no right or wrong answer. It's kind of like which one would cause more risk to the patient's life, right? Chronic alcoholism is a higher risk than monitoring liver enzymes, right? That can be treated and worked with, especially if you partner with a good internist or gastroenterologist. But long-term alcoholism, you know what the risk factors are, so a lot. The key is you have to document, right, that medication. That when you're seeing a patient, you have to document that you did the teaching. You have to document that the patient is aware what the risks are of staying on alcohol use, right? Or what the risks are of using, maintenance treatment to stop their use, right? And you have to document that the patient is aware that these are the risks of using naltrexone, right? But these are also the risks of staying on alcohol. And at least, you're giving them informed consent that you're giving them this medication for their alcohol use disorder. And there are risks with it, but they're aware that the benefits of taking it outweigh the risks of not taking it and staying on the substance, right? Does that make sense?
How long does someone usually have to be on naltrexone for?
It depends. Some people are on it lifelong. It really depends. There's so many factors. That's the tough part about addiction, right? There's really no right or wrong answer because again, people will relapse and you just have to deal with it as it comes. That's why you guys are gonna have great job security, unfortunately, because psych is chronic and these patients are gonna be coming to you for the rest of their life, right? Depending where you work. So you have to learn how to manage them, lifelong.
Is it the same for methadone? It could be lifelong as well.
Yeah, could be. Because the changes sometimes from the substance use of your brain, it doesn't, even though it tries to go back to the way it was before, sometimes it doesn't necessarily happen, right? Especially if someone has a family history of addiction, and let's say, I don't know, their first degree relatives were also addicted to opioids, they're genetically loaded, right? So even if you try to get them off, genetically, they have those epigenetic traits already, right? Whether it's sensitive opioid receptors or not enough 5-HT2A receptors or whatever. When they use it, it's very hard for the brain to compensate to go back the way it was before.
Could you just go back and reiterate the different pathways that we need to focus on? Like I know, because I know GABA's at play and glutamate's at play and If you could just
I'm
like,
not gonna ask you questions about the pathways. Don't worry about it.
no? Okay, all right, that works then. Thank you.
Only because there's so much other stuff that I want you guys to understand, which is the treatments that the pathways are at this point are just secondary. But do
Okay.
understand what upregulation, downregulation are. Like I'm not gonna ask you about the arcuate nucleus connection to the BTA or the nicotinic receptors. I mean, I want you to have a general understanding, but at this point, you don't have to. Unless
Okay,
you want
thank
to
you.
take my place when you graduate and you want to teach psychopharm, then you should know it. Why is it dangerous to give someone if someone is a chronic amphetamine user, right, and they come to you in the ER and they're very psychotic, and you know they're using amphetamine, they're psychotic to amphetamine, why would it be dangerous to give them a D2 blocker like Haldol? Or is not dangerous? I don't know. Maybe I'm wrong. What would you give them, Haldol? What do you think? What happens to your postsynaptic receptors when you're stimulating it with dopamine too much? What's going to happen to it? So your VTA secreting dopamine
Downregulate.
is you're giving. It's going to what?
Downregulate.
And downregulate, and what else is going to happen?
Like desensitize.
Okay, so what happens if you give them a D2 blocker then at that point? If their postsynaptic neuron is downregulated and desensitized, what's going to happen?
You're gonna block all the. There's no.
Yeah, you're
Nothing.
gonna block all the dopamine. Yeah, and they're gonna freeze up. They're gonna become a statue. They might have laryngeal spasms. They might. There's no dopamine there, right? So what do we usually do? We give them benzos to calm them down, right, and give their brain a chance to go back to the way it was. It might take a couple days, or it might take a week. But be careful with that. If someone you know is a chronic methamphetamine user, they come to the ER and the doctor's like, well, you're gonna be the one, quote unquote, the doctor, right? Ordering the meds. Do not order D2 blocker. Because again, they're gonna have downregulated and not sensitive dopamine receptors, and you're gonna block what they have left, right? Because over time, that postsynaptic receptor doesn't have enough dopamine receptors and very not sensitive receptors. So give them a benzo instead. If someone has a family history of psychosis and they're asking you for options of treatment for the alcohol, what treatment would you not give them? What treatment would you not offer them?
We wouldn't do the disulfiram.
Very good, right? Because you can worsen their psychosis. So if someone said, I just used heroin 2 hours before I came to the office, I want to start Suboxone, what would you do?
Wait
You
till
wouldn't
they're
give them the
third.
Suboxone.
Would you give them the Suboxone or you wouldn't give them the Suboxone?
You wouldn't because it would cause like worse withdrawal.
Very good, right? Yeah. And you have to make sure you do a what? What test would you use?
Cows?
Okay, and what do they have to score at least for you to start it?
Was it a 12?
At
12?
least, oh, at least 12. Yeah.
You said earlier, so if someone comes in and they're on fentanyl, the danger of them just giving the naloxone is that it's just going to run out. The naloxone's going to run out quickly.
Yeah, they need to be hospitalized. Yeah. Yeah. Because the fentanyl is a long half-life. So there's another form of fentanyl now that's even longer half-life. I forgot the name of it, but it's some form of fentanyl, synthetic fentanyl that even longer. So they need to be hospitalized.
So I'm in the ER and I know we do like a 4-hour observation period. And then obviously if they're showing like within that 4 hours, like no, like if they're still showing a lot of signs of like respiratory depression, then we end up doing a Narcan drip and then they get admitted and go to the ICU.
Yeah, definitely.
But yeah, I mean, we definitely don't keep them for 24. How would you there be signs you think though that they're like we're giving them the Narcan and it's wearing off after the 4?
I don't want to give the wrong answer because, like I said, I don't work in this field, substance abuse. So my knowledge is very limited. So I can't give you firsthand experience of what I would do or what I see. So unfortunately, I don't know the answer to that. Yeah.
Okay, yeah, because it's hard enough keeping them for 4. They get very angry when we wake them up with the Narcan.
I know, yeah. Yeah, I mean, substance abuse is, I have a general understanding of it, but it's not something I treat on a regular basis. I do cover substance abuse and outpatient because I do cover all the units in my hospital or my organization, but we don't get patients like that, so I can't give you firsthand information, unfortunately. Yeah. But it's scary. I mean, they put fentanyl in everything nowadays, right? It's like sprinkle. It's odorless, has no taste, so people put it in Xanax bars. They put it in everything, so it gets very dangerous.
Is there anything we should know about chronic pain then? I know like he was saying like we treat it with like SNRIs and stuff. Like, would that be more of like what you think would be on the test if there are questions at all?
So I usually partner with a good neurologist because if someone's having like neuropathic pain, so know that there is a descending pathway. So your dorsal horn of your spinal cord is your pain pathway, right? There's a norepinephrine neuron that when you increase norepinephrine, it dampens down the pain response, right? So you have the neuron that goes up, right? It was the efferent neuron that goes up, that goes to your brain and tells you you're in pain. So if you give someone norepinephrine, that's, let's say for instance, an SNRI like duloxetine, right? It's gonna dampen down that pain response. So we do use that for neuropathic pain. But a lot of times I'm not prescribing, let's say, duloxetine for pain, because that will be outside of my scope. A lot of times they'll be on pain meds already. But if I want to reinforce the gabapentin that neurologist is giving them, I might say, well, you're depressed. Let's do duloxetine on top of that also, right? But I would document it as, secondary. I wouldn't be treating the pain, but I would be treating the depression with some benefits of, duloxetine for the pain pathway. All right. So a lot of it would be SNRIs. There's milnacipran, levomilnacipran, which is also used. There are SNRIs also for pain. Obviously, gabapentin is used. But that's the extent of it, really. So just on norepinephrine dampens down the pain response. Sometimes anticonvulsants can work with pain also. Anticonvulsant meds can also help reduce pain.
So for this test, there's no like dementia on it or anything, it looked like, right? Or are we getting tested on that at all? Because I know the finals,
I'm still thinking about that
right?
because next week's lecture is supposed to be on sleep, but I'm wondering if I'm going to add like dementia on it. We'll see.
Okay.
Again, that's another, we don't, well, I guess you do. Yeah, if you work geriatrics, like you will see dementia. I do see it sometimes, but we can talk about it too. We'll do a deep dive on sleep next week. So don't sleep during the lecture, pun intended. So for 517, if you guys don't know, we're gonna cover all this stuff again, but we're gonna talk about like other stuff too, like what labs to order, the assessments, how to diagnose, all the extra stuff. So, but don't forget this stuff. This stuff is important too. Psychopharm is a big part of it. And we'll talk about more advanced prescribing techniques too.
So in 517, if there are no lectures, not even recorded lectures, we're
No, there
just
is recorded lectures. So
okay.
I don't know if they're going to change it for next semester. I'm not really sure. We are trying to improve the program, but again, I'm an adjunct, so I just follow what they tell me. Historically, like we'll do supervisions, like 3 a semester, which is like an hour long, in which you talk about your preceptorship experience, and we'll talk about like complicated cases and questions you have about the medications that you saw and how they were prescribed, and we'll talk about that. But when it comes to lectures like this, not really. This is pre-recorded lectures, and there's gonna be a lot of readings. And then during on-site, you guys will do a simulation, which there'll be like simulated patients, and I actually get to watch you guys on video. And then we'll go over about how you could have improved your assessment skills, and we'll ask you what meds you would want to prescribe. So that's how 517 works. Unless they drastically change it, which I'm not sure. But that's how it's been, and that's what I expect it to be.
is really the only CYP enzyme affected is 2B6 from methadone, or are there others?
This methanol.
Okay.
Oh, I forgot to talk about smoking. I'll talk about that next week. We'll add that. I forgot the slides for smoking cessation, but we'll keep that for next week. Smoking cessation is a big part of it also. Wellbutrin we use for that, Chantix, right? Nicotine replacement therapy. Okay, you should be. So if someone's on antipsychotic medication and they're smoking cigarettes, they automatically qualify for metabolic syndrome. Remember metabolic syndrome? I talked to you about fats, PHATS, elevated blood pressure, low HDL, adipose tissue that's high, elevated triglycerides, and elevated sugar. Even if someone doesn't have that, but they're actively smoking while they're on antipsychotic medication, you have to treat it like that they have metabolic syndrome. So you need to counsel them on smoking cessation. All right, it's very important.
Why is that?
Because
Why is
all the comorbidities of smoking, right? It's
Mm.
going to be worse. And there are, people who have dopamine deficiencies or dopamine abnormalities, like people who are psychotic or ADHD, they tend to self-medicate with a lot of nicotine, right? You remember that pathway I showed you guys, there's a connection between the nicotinic receptors and the BTA, right? So if you're giving them a dopamine blocker and they're trying to get as much dopamine from the BTA, what's going to happen is your body's going to crave nicotine to try to stimulate that BTA to secrete more dopamine, right? Because I'm giving you a dopamine blocker. So there could be reasons why they're craving that stimulation. Because someone's taking a dopamine blocker, they're not feeling pleasure, they're going to try to get that pleasure from other ways, like smoking cigarettes. So it might help with negative symptoms as well. But again, it's a risk benefits thing. A lot of people are vaping now also, but
I read in stalls that the smoking the cigarettes that you down regulate, your brain down regulates it by the end of one normal cigarette, and then it builds receptors that quickly.
yeah, that talks about desensitization of the nicotinic receptors. Yeah, so the reason why cigarettes are the certain length that they are, and there's a certain amount in the pack, because if they give you more than they have, your receptors are already down regulated, and it's like a waste of money for the cigarette companies to make more and add them to the pack, because it doesn't give you any more pleasure anyway. So apparently, I don't know if this style does mention it, but I don't know if it's true or not, is that the companies know exactly how long it takes to down regulate your nicotine receptors, and that's how they know how much cigarettes, how long the cigarettes are, and how many to put in a pack. But I don't know if that's true or not. But that's the science behind it, that the cigarette companies know exactly how many cigarettes it takes to downregulate those receptors. Remember, once you downregulate the receptors, it doesn't work anymore. So you're not going to get the euphoric effect, right? You have to wait for your receptors to cycle down again to go back to the way they were for you to feel that pleasure again. So by the time, I don't know, the next day you go to sleep and you smoke your next pack of cigarettes, those receptors are already back to the way they were before, so they can be innervated, right? If you keep smoking cigarettes nonstop, those receptors downregulate over time. You don't feel anything anymore because those receptors already have accommodated for that stimulation of acetylcholine from the nicotine. Does that make sense?
Yeah, it's just interesting that it just does that with cigarettes and maybe not necessarily like serotonin. The receptors don't become normal again so quickly as
Yeah,
smoking.
they do eventually. It just takes time. Yeah, some receptors take longer, some takes longer to go back to the way they were before. Yeah, they will eventually. Yeah, to a certain extent. There's like a book now called Dopamine Nation. Have you guys heard about that book? Dopamine. I actually have it. My wife bought it for me, but I never read it. It's an interesting book though. It's here somewhere. So the concept behind Dopamine Nation is that everyone's so used to social media that everyone's getting a blast of dopamine, right? Instagram, they're cycling, people want likes or watching short clips. But that means that your receptor, your brain is so used to that much dopamine stimulation that regular things in life feel numb, right? That's maybe why one of the hypotheses that maybe because people are getting so much dopamine, they're so used to that dopamine tone that the depression rates are high because people are not used to getting that same stimulation they get from social media, right? Like you've seen it before. People like, they delete their Facebook or they delete Instagram, and now they kind of have a mild dysphoric effect because they want to go back on it and get the likes and see that stuff. It's so people are starting to do dopamine fasting. Dopamine fasting means they might cut off social media for like a couple of months or stop using artificial stuff for a couple of months and then go back to it. The science behind that is it tries to put your brain back to a regular state and, hoping that, that you don't, I guess, overstimulate yourself and start feeling dysphoria from the withdrawal of it, right? Because people spend what, hours a day on social media and you're not getting other stuff done, right? Your family time, work time, all that other stuff is suffering. And then when you stop using social media, you get dysphoric, so you want to go back to it, right? It's almost like an addiction. It's a compulsion, right? It's technically a compulsive behavior. I open up my phone, I automatically go on Instagram. I scroll down my feeds for the day and I try to get as many likes as I can. It's compulsive. Once you stop that compulsion, what happens? It's very hard to turn it off and you feel dysphoria.
Can we go over those pathways a little, the compulsion versus impulsivity? Is it going to be as in depth as
No, not really. Not really.
okay? Because when
Like,
I
there's
when I
so many other stuff I want you to know, like the treatments and how that it's funny, the more that you go into like treatments, the less I focus more on the pathophysiology because the treatments are just more. So I want you to have a general understanding of it, but I'm not gonna ask you like I do know that when something compulsive, it changes pathways in the brain, right? It's more the dorsal striatum. You should know that. Something's impulsive, it's the ventral striatum. That's the reason why it's much harder to treat because it becomes a motor pathway, a motor disorder, not just a thought. Definitely know that dopamine is more for cravings, opioid is more for pleasure, right? That's why you give someone a dopamine blocker, they might still have pleasure, but they might not have drive for whatever object that it is, right? You have to give them an opioid antagonist to stop the pleasure feeling. That's why we give them, that's why if someone's using opioids, we don't give them a D2 blocker to stop it. We give them naltrexone to stop it. For next Friday, if I make it at night, will you guys be able to join? We do next Friday at like 8 o'clock or no? To the
Yeah.
morning? Is that all right? I'll make an
Is
announcement.
8:30 too late? Or is like,
I could do 8:30. Yeah.
okay,
You guys can do it.
8:30 would be better.
It's fine.
Thank you.
Thank you.
I could do 8:30 to 10. So I'm surprised a lot of people complain about the first test, but then some actually did worse on the second test when I wrote all the questions. What happened? Did it just throw everyone off? I'm not sure.
Can tell you that I mean I did better, but I still would have liked to do even better. But I focused on Edinger for the beginning, like was trying to now, like I was like, okay, well now I know how the tests are gonna be. I'm gonna study Edinger. I'll, still know Stahl, but not in that depth. And then it was, when you said that, I was like, oh great, okay, I'm gonna switch now. So I just think I didn't have enough time with the material, unfortunately.
I mean, the questions are more straightforward though. It was like no except or, select all and apply or, I tried to keep it pretty straightforward, but
No,
sadly,
it definitely, it was definitely a better test. And if I think that, like, because now, like I said, like, I think I was just studying Edinger, which is very different. And if I had more time to just study your lectures and stall, like, instead I was going through material when I would have liked to be studying material.
Yeah, I agree. I'm glad that I made that switch when you mentioned that it was going to be mostly stall. And to be honest, like I like the questions that you ask because it's what you focus on during the lecture.
Okay, good. Like the questions I want to ask are not just trivial questions. I want them to apply. Of course, the pathways, they could be trivial, but it's good to understand the pathways of dopamine because then you'll understand why the meds are causing side effects, right? That's why it's important. I know in clinical practice, it doesn't really, to memorize and recite the dopamine pathways, but it's giving you an understanding of it. All right, 2 minutes. Any other questions? So if we do lecture next week, that gives you guys 2 weeks, I believe, to prepare for the exam, right? So I think that's fair. And it's only gonna be like on 2 main topics, which is sleep and substance use. Substance use by itself is a lot, right? Because there's gonna be nicotine, which I'm gonna cover next week, alcohol, opioids, and stimulant use disorder, which is methamphetamines. Yep. I'm still teaching. Sorry, that's my wife. Any questions? No? All right, I gotta go. Thank you, everybody. Take care.
Thank
I'll put the
you.
announcement for next week. Take care.
Thank you. Bye.